Minister, please could you introduce yourself and your officers?
Deputy Tom Binet, Health Minister.
Ruth Johnson, Director of Health Policy.
Andy Weir, Director of Mental Health, Social Care and Community Services.
Ian Tegadine, Director of Workforce.
Rosalind Bullen-Bell, Director of Midwifery and Nursing for Women's and Children's. Daniela Rapio, Deputy Director of Public Health Strategic Commissioning.
And is your Assistant Minister going to be joining us at the table? She's around.
At the appropriate moment, yeah.
I can swap.
Okay,
Yeah,
okay.
that's fine.
Okay, so as always, the purpose of scrutiny in hearings is to seek information from ministers directly for the purposes of accountability and transparency on behalf of the public, and scrutiny, as always, functions as a critical friend. Today, we do have 2 hours, just under 2 hours now for this hearing, but we will have to be mindful of time because we do have a huge amount of questions to get through. Some sections we have already taken out of the question plan, so Minister, I would appreciate if you could keep your answers brief, but obviously including all the relevant details. And if I have to cut anybody off, I apologise in advance. It's because of the time. And we may also need to follow up with some of the questions in writing after the hearing. Could I just check that everybody has their mobile phones switched off, please? And welcome to members of the public who are in the gallery today and anybody who's watching online. We are going to open the hearing with some questions around our recent review into the prescription of ADHD medication. And Minister, thank you for your ministerial response. So we would like to understand a little bit more about the progression of the plans and activity in relation to some of our findings and recommendations. So first of all, the waiting list for for assessment and possible diagnosis as of the 28th of January was around 924 people.
That's right.
And you advised us that a seconded nurse was already successfully reducing that waiting list. Can you confirm if that nurse is still working on that, and why the numbers have actually increased rather than decreased as you might have expected?
Well, I don't. Do you want to? Andy will have the up-to-date numbers, but why it's increased? Presumably, it will decrease from now on. It depends on how many referrals come at any given time.
Are you aware what the waiting list is today?
As of this morning, I don't know if have you checked this morning.
900 at the end of February, 960 people.
Okay, so it's still going up. So yeah, could you give us some insights as to why?
So the nurse has not continued with her comment. She's gone back to her substantive role. We have offered we created in budget setting an additional post, which is a nurse specialist post for a nurse who is able to prescribe, and we've offered that post to someone. We're waiting for them to agree a start date and all of that. So that will be a full-time post. So that's a much better capacity for the service. Why is the waiting list going up? Really simply, as before, the volume of referrals, 32 to 33 referrals a month, we can see 12 to 16 people a month. That's the maximum capacity of the service. And as before, every time we take someone new onto the prescribing list, the capacity for seeing new people reduces because the doctors have to then see those people to prescribe for them each month. Okay. So simply, this continues to be a capacity and demand issue.
Thank you. Okay, and you said that somebody had been appointed, or that, and is it the People Hub processes that you're waiting on?
So in part, I'm trying actually to understand myself what the delay is with this post. So I made contact with the post holder at the beginning of the week to try and understand what's causing us difficulty.
And are all relevant government services, whether it's People Hub or any other services, are they aware of the urgency around the...
I think everybody that's involved with ADHD appreciates the urgency. I don't think anybody's particularly comfortable about having a waiting list that's that long.
What I mean specifically is of the onboarding of this individual who's been appointed. Could you commit to go back and check, Minister, that if there needs to be any unsticking of processes, that...
We'll certainly have a look at that.
Thank you. And
just ask really quickly, does that officer being in place increase your capacity? So the capacity is 12 to 16 a month. What would it change it to?
So we need to work that out, and that's about. And we have a meeting planned on Monday with the team and the clinical lead for mental health services to do exactly this. We need to work out how we're going to utilise that one person because she's a prescriber. We need to work out, are we going to get her to do more of the prescribing, which means that particularly the junior doctor might be able to do more diagnostic work, etc. So significantly increases the capacity of the service, how we utilise the different people will determine whether it most impacts on prescribing, waiting, support, all of that stuff.
And you're not stopping at this one nurse, are you? Because there's another 2 that you're planning to take on board, is that?
So that's not correct. There are 2 nurses in adult mental health services who are training to be prescribers, but they don't work in the ADHD service, and they're training to be prescribers in the service that they work in, which is general adult mental health services. So I think one of the things to explain is that it's not just find a nurse prescriber and put them in the ADHD service. Nurses need to prescribe within their scope of practice, so actually they need to have trained in ADHD in order to prescribe in ADHD. That's not what those nurses are doing. They don't work in the service now, and there's no funding for additional posts in the ADHD service. So they will complete their prescribing course and they will work in the services that they work in as nurse prescribers.
Can you describe what that will look like specifically for adults with ADHD then? Will there be different pathways that they're involved in?
No, those nurses, I would detach those nurses from the ADHD pathway because that's not what they're there to do. So one of them works in the crisis and home treatment team, crisis and assessment team, for example. So she'll be prescribing in the crisis and assessment team. There are equally people that we see out of hours at weekends who need prescribing for. So having nurse prescribers in other parts of the service is equally as important. But it's also part of the choice of the nurse. The nurse needs to want to work in the area that we can't just say, you will go and work there. They need to have skills and experience in the relevant place.
To just clarify then, so you're getting 1 extra person, that will increase the capacity of the service. Yeah. Is there anything else being done to increase the capacity of the service right now?
Yeah, so the other thing that we're doing is we're delivering psychological therapies now. So we know that we've got people that are waiting because medicine isn't everything. The sole answer to the ADHD difficulty isn't just to give everyone medication. There's lots of other things that you need to do. So we are now delivering, for example, a Living with ADHD group, which we're just going to repeatedly offer to and deliver to people that are on the waiting list so that they can help manage and live with the symptoms in a different way.
Okay, so I'm trying to understand the 2 nurses because in the response to our review, we were led to understand that this was to reduce capacity. So those two nurses will be prescribing ADHD medication, but within other services.
Have nothing to do with
So
the
why?
ADHD.
I'm just trying to understand why they were mentioned in the response to the review.
So I think they were specifically mentioned within the review, weren't they? And I would hope that the response does say that the nurses are not going to work in the ADHD service. Indeed it does. It says the 2 nurses that are undertaking the training currently do not work within the ADHD service, and to redeploy them into the service, should they wish to do so, will require additional financial investment and the need to replace them within their current service.
Okay, so have you established whether those nurses would wish to work within ADHD prescribing?
So they're not training to work within ADHD prescribing, they're training to prescribe within general adult mental health services.
Right, okay, so disregarding those 2 nurses, are you planning to train any other professionals aside from this seconded nurse?
I think the point we've got to make here, and I think this is going to be the answer to a number of questions here today, is we do not have any additional funding. I think we need to make that absolutely clear. So we haven't got the money to train additional people and put them into those places because we haven't got any additional funding. Unless I've got it wrong, our budget is entirely spoken for.
So to clarify,
it's not for lack of wanting to. I have to say, in an ideal world, we'd be training people, we'd be reducing those waiting lists. We'd also be providing better care for dementia and so on. But we are where we are, and we have to be honest with you about that position.
So obviously we understand that you have a pot of money, you need to prioritise it. So is your response that the money is not being prioritised towards this service at the moment beyond the one additional nurse?
Money. I think we've got to be careful about our terminology. I could give you a list of a dozen things where money should be prioritised, but the budget we have is spoken for in all areas. So there's no spare pot of money that can be apportioned to this or to that. At the moment, we're frozen into the situation we are at the moment, and unless and until we get sort of more funding, then that position will remain, however unpalatable that is.
Just to be in the theme of being honest with the public about this, in terms of that extra person who is coming in, hopefully, starting maybe next week, it will increase capacity. Will it at least get to a break-even point, if you like, where the rough number of referrals that you're getting will equal the capacity to deal with them.
I don't mind making a comment on that. It strikes me as, I think, a common sense approach to this, that the numbers cannot keep growing because we haven't got 100% of our community with ADHD. So there will come a time when those numbers, the increase in the number of referrals will diminish, and hopefully then we can start biting into that number and bring them down.
So you're relying on that sort of, the curve flattening more than you're relying on the increasing capacity within the
It's worth
department.
saying that you already know that we're doing quite a lot of work about increasing funding and perhaps introducing charges in various areas of healthcare to improve the budget. So that work is ongoing. So it may well be the case that in the fullness of time, we can draw in more money. We can then start to look at how that money is apportioned. But until that work is complete, and then it's got to be agreed. And that is something that we'll have to talk to the public about, because that's a fundamental change in the funding model. And that's something we are looking at.
So is it fair to say that were there additional money, this is one of the areas that you would prioritise?
I would say it is, yeah. I think the fact we've got nearly 1,000 people on the waiting list is a concern to absolutely everybody. And we don't sit here feeling proud about that. That's
Understood.
it's something we'd like to see addressed.
And I'd like to ask about the waiting list. What is the current waiting time from a referral to an assessment?
My understanding is 4 years and 7 months, I think, yeah.
Gosh,
If
okay.
you're referred today.
Okay. And you mentioned some other interventions that not just pharmaceutical treatments for ADHD. Could you expand on what is being offered at the moment?
So the psychological therapies team are initially, so they're offering a number of things, actually, offer a number of new groups for people. But one specific group that they're offering, as I say, is living with ADHD, that's what it's called. And people on the waiting list are incrementally being invited to participate in that, should they wish to do so. We think that probably what will also happen is some people, once they come to that group, will find out about other groups that we're offering and hopefully engage in some of those as well. So that's the type of stuff that we're doing.
Okay. Has there been a good uptake of that?
So I don't know, actually. I can find out what the yeah.
And
I'm
how
sure
will you, thank you. And how will you, Minister, how would you measure, so these additional things that are being offered, how will you measure the effectiveness of those?
That's really a question for Andy, because the mechanisms for measurement would be something that would be closer to him than to
So
me.
we generally ask people about either symptoms or their experience before they start the group, and we ask them again at the end of the group. That would be the normal way. We'd specifically ask people, what's been helpful, what if it's a few sessions of group, then we'll ask people to tell us what's the stuff that's really helped for them. And as you would expect, different people give different responses. So.
Yeah. And is that going to be qualitative data or would okay? Are there clinical measures that you can use?
So this isn't really a clinical group. This is a more of a group that's led by our psychology assistants, overseen by one of our psychologists. But this is about information giving and teaching people some basic skills. This isn't complicated, psychotherapy. That's not what we're doing.
Yeah. Okay, and the panel, during our evidence gathering, we became aware of some groups in the island who are offering similar services. How are you supporting those groups, Minister, to deliver those services?
Well, you'd have to be specific about those groups.
So charities, support groups, there are some that take the form of online support groups, they're offering courses, they're offering peer mentoring. I understand there are a variety of different things being offered.
Yeah, I don't think there's any more support available than what they're currently getting, and I don't know that there's a great deal of support from us on that at this point in time. Andy, you might know otherwise, but
So shortly we will publish the neuro-inclusive strategy, which is in its final draft at the moment. That has a section specifically on it around charities and third sector providers and getting people to work together in a different way to offer a broader and more joined up set of approaches to people. So I'm hoping that will take care of that for us.
and we are engaging, I have to say. Whenever we can, we have discussions with various people involved.
Okay, so you're mindful to support those activities
To the fullest extent that we can.
Okay, thank you. Yes, the go on, do you want to answer?
So there was talk about publishing waiting lists. Is that going anywhere?
Not yet. So we've agreed we're going to, in principle. The meeting on Monday is going to agree how we're going to do it. So where we're going to publish and how often.
And you will communicate with people on waiting lists?
Certainly will, yes.
Okay, fine. There was a recommendation around the dedicated hub that was rejected, Minister, on the grounds of cost. I think your words were it's going to cost a hell of a lot more money, and in any event we need more staff. Was there any kind of costed model produced? I mean, or was it just a general kind of, look, this is going to cost money and we're not going to do it?
Unfortunately, when you look in the pot and there's not a single penny, you know you can't leave the starting blocks. Doesn't mean that we won't look to try and do this as things go forward. As I say, we need to have a fundamental rethink about health funding. I think in Ireland, where you pay 20% tax and year on year you get health provision is more and more complicated, more and more expensive. You then have to have an honest discussion with the public about what sort of health service they want and how much they're prepared to pay for it. It doesn't mean that the idea isn't a good idea in principle, and it's not one. It might well be one that would be supported if there was sufficient funding. Because, as I say, anything that can help to bring down a waiting list of nearly 1,000 people on 100,000 people is something you've got to want to do. But,
So you're supportive in principle?
the principle is fine.
In terms of funding, is this something that you have approached any other ministers about? For example, the Chief Minister has a fund for pilot projects that would perhaps fit well with this.
No, I haven't, because as I say, I could list as long as my arm of people who make very, very compelling cases, both collectively about individual illnesses and conditions, and specifically individuals who've got their own personal problems. I think states members will know from some of the emails that get sent to all states members. I think there was one yesterday evening which highlighted a specific problem, and once again, the problem is money.
Are you aware of how much money could be saved were ADHD issues associated, perhaps related health issues, money that could be saved if the treatment was improved?
Those principles apply to just about every area of medicine. Virtually every single one, those same principles apply. Early intervention with stroke, with heart attack, diabetes. There's an awful lot. We are working on a strategy to try and move from a reactive to a proactive health service, but that's going to take an awful lot of money. And we'll be sort of looking to take measures to try and see whether the Assembly is minded to support that.
I wonder if any of your team have any awareness of any, perhaps public health, of any savings, a ballpark understanding of what money could be saved on treating related health issues if we treated ADHD more effectively.
So we don't know in relation to ADHD, but as part of the Director of Public Health annual report, there's lots of detail in there about the case for change for focusing on prevention, which we all know prevention is better than cure. But that is a bit of an investor save, because you need to double run for a period of time. And when you've got increasing need and increasing complexity of need, it's quite difficult to shift current health funding to the preventative model. But we are looking at that.
Thank you. In terms of the... I'd like to ask about the shared care model, which I understand that there have been conversations ongoing. Could you provide an update on these conversations, please?
Well, Andy can provide an update on the discussions to date, and I can just say that going forward, I'm now due to have a meeting with the GPs myself. But if Andy, you want to comment on
Minister, before we hand over to Andy, could you let us know what previous meetings you've had with the GPs?
On this particular issue, I haven't. It's been done by the professional team.
I recall at a previous hearing you committed to meeting with them. Is there a reason why that hasn't happened?
Yeah, time as much as anything else, but I've also been aware that the professional team have been in dialogue, and I was hoping that was going to unlock the situation in itself, because, as I say, I can't be at every meeting all the time. Unfortunately, we still haven't managed to resolve it, so I am now going to, hopefully next week, meet with the GPs.
Okay, is that meeting in the diary for next week?
No, it's been discussed this morning, and it's been requested this morning.
Okay.
So that reflects a problem. That there is still an outstanding issue with the GP in terms of trying to get the GPs involved.
There is, as I say, I was hoping it was going to be resolved at officer level, but it hasn't to date. So.
Could you give us some information about the officer level discussions, please?
So there's been a further conversation with the Primary Care Board representatives. Following that, there was a meeting of Primary Care Board members, and their decision was that they would not support a shared care model currently. So that's unchanged from the last time that we reported here.
What was the ratio of those supporting and not supporting it?
So I don't know, because clearly I wasn't at the meeting. I just know the outcome of the meeting. We've also had the executive directors from HCJ meet with primary care board members. We had a meeting at the end of last year where we talked about this in some detail. And again, the view was that that's not something that they felt they could sign up to at the moment. And clearly, from my perspective, this is absolutely key to creating capacity in the service. You know, we will eventually get to a point where all we can do is prescribe for the people that we've diagnosed, and we won't be doing assessments because actually there's no one else to prescribe.
Yeah, and we understand, Minister, from our evidence gathering that there are some GPs, whether it's whole surgeries or individual GPs, that are prepared to enter into this agreement. Is there a possibility that agreements with either individual GPs or perhaps one or two practices could be entered into?
I'm very hopeful, but I'm not sure that I've got anything else to bring to the party. I'm certainly going to have the discussion with them and see if they can be persuaded, but I can't sit here and guarantee that I'll have any more success than Andy has, but we'll certainly make every effort.
I think what I mean is it practically possible in terms of the shared care pathway? Is it possible to do it with
their agreement? Yes, it is. You don't have to have every surgery offering that facility, but it's really to try and get to the nub of why it is that they're not prepared to let certain individuals do it, and that's the nub of the discussion.
Have you got any indications about what the concerns are?
Yeah. So yeah, they've said consistently. So there's a couple of things. So firstly, there's training and experience. So a number of them are concerned about prescribing the types of drugs that we give for ADHD. Secondly, there's a concern about capacity overall, and a view that this is specialist work that should be done by specialist people. And then thirdly, the issue of the availability of medicines, which is a complicating factor because sometimes we will have, a less availability of a certain medicine, and the specialist needs to then adapt or change the medicine to one that's available. That continues as before. We still have peaks and troughs of medicine availability. So they felt at this point in time that's not something they would want to take on. But I think this is not just here. This is a debate that's happening in lots of jurisdictions about what's done in secondary care versus what's done in primary care.
Sure. Okay. And Minister, I know you've mentioned funding at the moment, but funding for training those GPs, if that is the main concern, would it not be worthwhile investing in that to unlock that shared care agreement if that's the sticking point?
All of these things, if that becomes a sticking point, we need to look at what that is and how we might be able to shuffle. I mean,
so there's potential.
There may be a case for shuffling things, but I say I'm always very, very reluctant to commit to make financial commitments against the backdrop of what we're confronting at the moment.
Sure.
Yeah. But there is, I have to say, I'll make the point again because I know we're on air. We are very, very keen to get this problem resolved.
Sure. And is there potential that if there were an ADHD hub established, that there could be a GP maybe based in the hub, full or part-time, to deliver some services there?
So where we deliver diagnostic services from is about what's clinically appropriate. So yes, you in an ideal world, I think where the newer inclusive strategy will lead us to is a place where you have a multitude of things going on in a place. And that might not just be ADHD. I think there's a wider question about you could be doing other work there as well. So yeah.
Absolutely. Yeah. Thank you. Do you have anything final on ADHD? Okay. Anything on ADHD, anybody?
Yes, please. On the last occasion, I think Mr. Weir told us that there was some consideration being given to the possibility of prioritising or triaging the waiting list, and I wondered if any progress had been made on that.
So we have done some work on that. The clinicians clearly have done some work on that. They have some proposals around prioritisation that we're going to talk about on Monday. I think it's fair to say there are very mixed views about this. And I think we will have to make a decision about prioritisation, but certainly the clinical team have thought about how they would want to prioritise referrals.
Thank you. Yeah, thank you. Okay, so the next section is going to be on the restructuring plans for Jersey's healthcare system.
I wonder if I could be a little cheeky, first of all, Minister, and say you've talked a couple of times about increasing charges in some areas, which is a kind of an overarching thing. Can you give any more information about what kind of services you're thinking about increasing charges on?
Oh, that's very, very much in its infancy, and I wouldn't want to make any particular. Actually, there was a meeting that we had to cancel today that was going to give basically a first picture of the available opportunities. So that's imminent. That's now next week. So we can, as things, I'm very, very happy to be open and honest about that as we go. But what I don't want to do at a too early stage is make statements to start frightening people about this. It's something, it's going to require more money, so we need to handle that very sensitively. It is very, very much, that's very much more a public engagement thing. So we need to be cautious about what we say when we say it.
So there is some public engagement. Good.
Whenever it's appropriate, sir, it will happen. I can make more plans. I can make more comments on that in relation
so
to this
let's
too.
talk about the restructure then.
Yeah.
Let's try and get some information clear first of all. What stage are you at in terms of the stakeholder consultation?
We're reasonably advanced, aren't we? We stay in touch with people, but the main consultation work is done, isn't it? Ruth has been handling that, so she can give you the full detail.
As you will be aware, the Health Minister took some initial proposals, high-level proposals out to consultation with key professional stakeholders. It was not a public consultation because it was focused on talking to key professional stakeholders about how we bring forward arrangements to support them to work better together. That consultation has been finished. As a result of that consultation, we, because it was shown universal support, we are currently working on some draft terms of reference for a partnership board. As soon as those draft terms of reference are completed, we will be going back to those key professional stakeholders to talk to them about the draft terms of reference. So that will settle matters as to how that board is constituted, who are the members of those boards. At that point, we will also be coming and talking to the scrutiny panel and also PAC, because that is a requirement of P170/2010. And then we will be bringing those draft terms of reference and the proposal for the establishment of the partnership board to the States Assembly for decision making. So that's the status of consultation with regard to the partnership board. As you will also be aware from the previous States members briefing, we are proposing some internal changes to reporting lines within Health and Care Jersey, and also some changes to a very small number of existing staff's job roles within Health and Care Jersey. We are currently actively working on developing detailed proposals for those new reporting lines and those new job roles, and we will be consulting staff about those, all affected staff about those, towards the end of this month.
So in terms of the other thing that was mentioned, certainly by the Chief Executive, that PAC was a business plan, which you would expect with these kind of proposals before it goes to Council of Ministers even. Where are you with the business plan, Minister?
Well, with the Council of Ministers, we've kept them updated as we go.
So with regard to a business plan, there is one area of cost within this. So obviously you develop a business plan when you have an area of cost. There was one area of additional cost within this, and that area of cost relates to the partnership board. Alongside developing the draft terms of reference for the partnership board, we will be developing the associated costs. And obviously the cost of the board will be dependent on the final terms of reference, the constitution of its membership, how often it meets, and so on and so forth. All that information will be presented to the States Assembly for decision making on cost benefit analysis, because as you will recall, it is a requirement of P170/2010 that the decision making sits with the States Assembly. But the costs associated with the development of the partnership board are very small indeed.
Picking up, though, the Chief Executive pointed out that it was an important part of the process, and that he said there was active work on a business case at PAC. So
unfortunately, I can't comment on that.
I think what we're saying is it's going to be limited, because in reality, what we just need to be doing in the business case is just focusing on the money. I take it you've got concerns about the structure itself.
I don't think I have enough.
I shouldn't be assuming.
I don't think I have enough information to say really. I mean, nobody disagrees. I think with the broad principles of what you're trying to do.
Well, we've made
the devil is all in the detail. So I think what I'm trying to establish at the moment is when will we know? So when will it go to the Council of Ministers as a detailed set of proposals, and then when will it come to the Assembly?
So depending on the outcome of the consultation with key strategic partners on the terms of reference for the Partnership Board, we would envisage it going to the Council of Ministers in April, and we would envisage it coming to the Assembly in May. And before it comes to the Assembly, we will of course brief Scrutiny and PAC on it.
So there's a draft terms of reference that's part of the consultation.
The consultation will be on. So this is the kind of the second phase of consultation.
Okay.
For want of a better description, it will be on the draft terms of reference, and they are part written at the moment, just not at a stage where they are finalised, ready for consultation.
And part of the problem is an overload of work, isn't it? Because unfortunately, we haven't got a team of people just sitting there waiting to draft everything. We've got a lot of pressures in a lot of areas, so it's not progressing as quickly as we would like in an ideal world. But that's just a product of where we are.
So the one question that I think sits underneath all of this is the way you've chosen to do this is, you know, you've obviously come under questioning about that. But one of the things that would be interesting to hear is, what are the aims in terms of public improvements that we might see as a result of this? There surely is some baselining in terms of, this is what the situation is now, this is what we'd expect to see in the future, relative to patients, not in terms of just a job changing.
Well, the whole idea of this is to deliver better patient care, isn't it? I think that's got to be our focus in all areas. And I said when we talk about restructuring, there are two parts to this. There's the formal creation of a health board, which is simply really trying to get a forum together where all the participants feel that they have an equal stake in it, and they've got a forum for discussion and decision making, which we lack. And it also puts us in a position where the overarching department has responsibility insofar as it can have for all elements of healthcare, and somebody sits at the top with a brief and a salary that requires them to deliver a fully integrated health service. We don't have that at the moment. It's incoherent in my view, and that's why we're looking to get the model straightened out. Within that model, there's other work going on, and I've mentioned this time and time again, that that's just a personal opinion, I think it's shared by just about everybody else, that everything was over-centralised in the Parker regime. Everything came into central government, and that was finance, procurement, HR and IT, and that's caused a lot of complications. And what we're trying to do, I don't want to use the word decentralised, but there's an element of decentralisation in this. As we've said before, everything will run through the central system, but there's more autonomy within the health service itself. So we're trying to create a sort of fully integrated health unit, so that health can actually look after itself. The finances can be handled by a finance director with all the required skills. The same with HR and the same with IT. And it's a shame that you've got digital is not on the agenda today, because there's some really exciting stuff happening in that area, and it's a very vital area.
I'm sure we can move on to it. But with respect, can I just push you on the question I asked, which was about what difference you expect the patient to see? Because I understand all of that stuff in structural terms.
No, that's fine. And forgive me, I didn't fully address that. From what I've seen in now 14 months, is that an awful lot of the problems we've got is the fact that things in the health service generally don't seem to be closely enough connected. A lot of things fall through the gaps at various times, and that's why there are two elements to this. There's personal connectivity, where the right people get to talk to each other more regularly, and the other is digital connectivity, which is the overarching requirement. And at the moment, there's an international standard of where we are on the digital pathway, 7 stages, and we don't get to the bottom of the first stage, to the front of the first stage. That's how badly off we are. So in terms of personal connectivity and digital connectivity, lots and lots of things go wrong when you go from primary care into secondary care and back out into the community, and those things need to be tightened up.
So when you say that things go wrong, I think the question is trying to focus on the patient experience.
The patient experience, not the information doesn't travel as it should. Partial information gets through. Gaps emerge in terms of timing. So there's an incomplete pathway, and timings can go wrong. And people don't know. I mean, and when people get sent away to the UK in terms of records going over the records of the work that's done coming back, it seems very, I know I'm a layman, but it seems very, very fractured to me. And when we've had these discussions, I think it was 14 sessions we did or more,
Yes.
everybody was in agreement. that, I said to people, if you were designing a health service, will you design the one we've got? And not one person in that process has said that they'd have what we've got. So whether we're going in the right direction or not has yet to be seen, but I think we need to be going in a direction because nobody's happy. Nobody within the professional area is happy with what we've got.
I mean, and the baseline is what I'm after, though, the data.
Yeah.
How will you know that this has worked? So I presume there's some sort of sense of this is what's not working and these are our indicators of it not working, and then we'll know whether it has worked.
Is it waiting times? Is it life expectancy? What are the actual measures?
I think one of the measures I'll notice is I'll get less emails in my inbox to reply to from people who are not happy with the service. I say that partially in jest, but it's
Complaints could be
it's
a
quite
legitimate
true.
measure.
I mean, complaints will be an indication, but I think with all of these things, you have to have a bit of faith in a concept and think, well, actually, it makes sense, and you just get on with it, and there will be measures that you can where you'll be able to gauge whether it's working or not.
That's critical to me.
Yeah.
I mean, I think what you're saying is we should just suck it and see, and we believe it will work.
Yeah.
What I'm saying is, normally you would expect to see a data-driven approach where you say, this is the problem, this is the baseline where we're at, this is where we want to get to, and here are the measurements which will show whether we've got there or not.
Perhaps I haven't given sufficient thought to how we might analyse the success or otherwise of this. We're up against a political cycle, which is a worry, and I'm always a great believer if you come up with a set of ideas and they're fine-tuned by talking to people and everybody's happy with them, it just makes perfect sense to get on and do them. And you can start measuring the success or otherwise as things start coming together. As I say, we can stop in our tracks and make sure that the model's perfect, and we've gone out to the public and we've got all the measures in place. You turn up with an election, somebody else comes in, the whole process starts again. So there's this tension between wanting to make sure you've ticked every box to get the technicalities right and getting on with the job. And I'm afraid for my sins, I tend to err towards when something looks right and the professionals are all in agreement that that's the way to go, you crack on and you get the job done.
Thank
So
you.
I'm quite happy as a result of today's discussion to go back with the team and start thinking, perhaps we should have thought earlier, but I take on board that we'll need to have some measures in place to monitor. I'm quite happy with the principle of measuring success, but for me, up till this point in time, the main thrust has been getting on with the job. But you make a very good point about assessing.
Would you reflect on the future Jersey indicators, which I believe are being used by government as a whole?
We can put that into this as well.
It goes a little bit further than that as far as I'm concerned, because this is very interesting, but I am confused, to be frank, as to what exactly is proposed. And I understand that when you're trying to reorder what is a huge department with multiple problems in it, a whole lot of ideas are thrown around, but there comes a time when you must reach a decision, this is what we want to do. And it seems to me that it would be enormously helpful to members if you were to put out some short paper saying this is what we perceive the problems to be. This is how we're going to deal with them. It's more or less what Deputy Renouf is saying, but it's perhaps a different way of expressing it. I
had hoped that we'd done that when the engagement that we did on the 5th of December. There were questions asked in the Assembly.
It's not in writing, Minister. I mean,
But some of that is in writing. There's an awful lot that's been put in the public domain.
I've got this, but that's the Integrated Health and Care Consultation Feedback Report. Is there something else?
So no, there is not a single document that captures the direction of travel that is currently being driven by the Health Minister at the moment. There are a number of pieces of work that are going on which have the sole intent and the sole aim of improving the health and care services and the access to health and care services in Jersey. The Partnership Board is one of them. Clearly, the new hospital is another one. There is individual pieces of work that are being done around specific services and around specific areas of public access to services, termination of pregnancy, IVF, etc. They're absolutely recognising the what is at the heart of your question. I think it is really important to acknowledge that the establishment of a partnership board will in itself not create positive change for islanders. What will create positive change for islanders is the output and the work of that partnership board. So it is the key providers of critical health and care services coming together to determine what the priorities for change are and working together to deliver those priorities for change.
Yeah,
So
I
it
think
is-
I'm just going to stop you there, Ruth,
Yeah.
because I'm mindful of time. I think that's understood, and what the deputy is asking is, when will that document be available with all of these principles and the model set out so that we can scrutinise it and the public can be aware of it? When can we expect to see that document?
I'm going to sit here and correct me if I'm wrong,
So-
but we hadn't actually got a plan to put a completely coherent document putting all of these things together. I mean, I make the point, and Ian's going to touch on some of this, and when we finally do digital, we'll touch on that as well. But a lot of these things are already happening.
One of the first tasks of the partnership board, if it is set up subject to assembly approval, will be to develop a whole system health and care strategy and to own that whole system health and care strategy. And I believe that is the document to which you are referring.
Well, you need something to get your teeth into,
Yeah,
because if you don't have any specific document and with specific proposals, you can't identify them. Some people may not be entirely happy, Minister, at the proposal that the health insurance fund should be transferred to the health minister from the social security minister. At some stage, there has to be the possibility for members to debate that before it becomes a fait accompli.
They certainly will, and that will come when we come with the proposals with the terms of reference for the health board, because that's the partnership board, because that's all part and parcel of it. And I'll make the point again: all we're doing is that transferring it from one department. At the moment, there's a lot of complication in terms of how benefits are paid, and there's an enormous amount of complexity that could be streamlined. And all we're looking to do is transfer a fund in its current form, with exactly the same purpose, from one department to the other. It seems to be a very good idea to us, and the Social Security Minister feels the same way. I don't see any contention in that, and if people have got questions, that's fine. But those questions will be answered when it goes to the Assembly as part and parcel of the proposals for the health board, for the partnership board. Sorry.
Is your intention to keep the fund as a ring-fenced fund?
That's the intention, yeah. But like as I say, going into the future, I think we have to be prepared to look at everything, and we have to have a fundamental review of health funding. So what the recommendations are as a result of that, we shall have to wait and see. But there's certainly no intention for the GPs not to be properly funded. That's for sure. I mean, I've been down that road myself and supported measures to not have that fund raided. So those principles will be preserved throughout. That's absolute.
Can I just ask for some clarity then about, just to go back a couple of comments? So is my understanding correct that you're trying to work towards getting the system and the structure in the right place so that the big conversations about how to make the improvements for the patients can then happen?
Yeah.
So it's kind of very much a staged process, which is why we don't have one big document setting it all out yet.
Yeah.
Okay. And then if at that process, if at that stage when the big conversations can happen, first of all, how far down the line are we looking at that timeline wise? And if then it emerges the structure isn't correct to get those things done, because it's kind of a chicken and egg situation, isn't it? Is the structure going to be right to serve those purposes? Well, you might not know until you know what those aims and purposes are.
We know what the aims and purposes are.
Why haven't you told us?
Well, we have. People came. We've had briefings, and we've offered to do another briefing. There's a date in the diary now where we're going to brief people, and people are free to come along. I think only 8 turned up the last time with 2 online. I'd like to see 49 people present. Very happy to talk to all of it, and there's a logic to all of it. And as I say, perhaps I'm closer to it. I'm a little bit confused as to why people can't see the logic of it more readily than is the case. So perhaps we're not communicating properly. But the formation of this board is, in my view, perfectly logical. And all the people that we've put it to that are in the professional services are looking at it saying, that looks right. I don't think you can go any further than that. What you then have to do is to get on and do it and put it to the test. And if it needs fine-tuning, then it gets fine-tuning. Our health service is in quite a lot of trouble. I say my inbox is testament to that. And we need to go on and do stuff. And I apologise if we're not spending quite enough time on process. That may be a fair criticism, but we do really need to do something. And I'm afraid to date I haven't seen enough things happening. So
I'm not being purposefully difficult. I genuinely don't understand.
I'd like people to leave this room feeling a little bit more comfortable about the fact that things are really some positive stuff. And I know nobody wants to focus on it, but as I say, I think in HR and recruitment, there's an awful lot of good work that's been done. On the digital front, we've got a head of digital. We've actually got a digital director, and 30 people have been apportioned for that person specifically to work on health. I mean, that's in my mind, that's something to celebrate. It's groundbreaking stuff.
I do feel like I was starting to get somewhere with the understanding of the stage process. If we could just go very quickly
I'm
back
just
to that.
enthusing about it because I want to get the message over.
It's a staged
Yeah, of
process,
course it is,
and that is the idea, to get a system that allows everybody to sit comfortably around a table and have input. So just back to the question about timeline, about when that conversation is going to happen, be able to happen.
Okay, so assuming that the States Assembly agree the establishment of the Partnership Board, we would envisage that we will start that work with the Partnership Board towards the end of the summer, because of course there's a sequence of decisions. Decision by the Assembly to establish the board, recruitment to the board members. As soon as that happens, we will start the conversations with the members of the Partnership Board about what an overarching health and care strategy looks like and what the priorities of change look like. So that absolutely will be before the end of this year. And to be clear, the Partnership Board will be undertaking and leading public consultation during that process, because that will be the conversation about what does change look like.
When is that debate going to be?
So that will be before the end of this year. As I've said, there's a sequence of events, which is States Assembly agree,
Yes,
us being able to recruit.
So that first thing that you mentioned, the States Assembly agree, what state sitting will that debate be happening at?
So it will hopefully be in May.
That's the target date.
That is the target date for getting the report and proposition lodged, so the States Assembly members can debate it. We will then recruit the members. We will then start working with that Partnership Board on what a health and care strategy looks like. Going back to your point about if it turns out that the structure of the Partnership Board is not quite right, because it's impossible to completely know that until we commence work, the Partnership Board will not be in statute at first. So if we need to amend and flex, we will absolutely amend and flex. And the other thing to say that's really important about the reason why this approach is proposed is the Government of Jersey has historically spent a lot of time and a lot of resource historically developing health and care strategies. For example, the Jersey Care Model and P82 back in 2020, and those strategies have not been successfully progressed. And if you strip away to the core reasons for the failure to progress those strategies and create change in the past, it is because the essential system players did not feel ownership of the development or ownership of the delivery. That is the fundamental problem we are trying to resolve
That's
in
helpful.
the first place.
You mentioned P82. What measures were used to measure the effectiveness of the actions within P82?
I would have to come back to you on that because, of course,
Well, that's
PH2. So PH2, of course, was very broad brush. It included the development of a new hospital, and I that's historical. I would have to go away and I would have to.
That could be
find
referred
that
to when the minister's considering
yes,
measures.
absolutely, and at the point at which the partnership board develops a whole system health and care strategy, there will be very clear indicators of change within this. What is it that will be better for the public as a result of us doing this?
Did you finish your line of questioning? You did.
it's great,
Go ahead.
Just while some of the
Sure.
while some of the conversations have been taking place, I've just been thinking about examples of where things can be made to be more efficient. And one of those, we've currently got a problem with talking with the GPs to try and persuade them to have this shared care pathway. I wouldn't mind betting that if the GPs are formalised and they've got a voice and they're on part of a board, those discussions become a lot more direct. There'll be a lot more trust. When I first came to this, the trust between the services and the GPs was really in bad shape. I have to say there was a lot of animosity both ways round. I think that's already. I think there's some trust building up. There's more engagement, I think, than there was, and I think. Particularly with the GPs, if they're a part of a board and they've got the status, they've got a voice, those discussions will be, the problems will be discussed on an ongoing basis. As things emerge, they'll go straight to that body, the discussion.
Yeah.
There'll be more trust there, and I think those issues will be resolved a hell of a lot more quickly than they are at the moment. That's the hope.
Just a final question perhaps on this. I mean, to Deputy Balash's point really.
Yeah.
No health minister sets out to design a system that makes the system worse. So, that's taken as read. Maybe not by you, but I don't think any health minister has stood there and said that.
I wouldn't say that at all.
So the point is that, yes, you are trying to make the system better, but the devil is in the detail. It could, you believe that by putting everybody in the same room, conflicts will be resolved better and so on. But it may simply transfer conflict into a new forum. It doesn't make clear where the lines of accountability lie. It doesn't say where the resourcing will go, how, who will take responsibility for different things. So that is the sense in which I think Deputy Balash's point about wanting to see the detail. How will this actually work? Will it? Because then we can say whether we think it will deliver the change.
That's fine. But I've seen successive health initiatives come to nothing. Okay, and however well-intentioned a person might be, and I'm afraid I just come from a real world background where if you don't get on your bike and get things done, people overtake you. So we're not in that situation here. There's nobody that's going to overtake the health service. But you know that things just don't get done. So I have to say, from a political perspective, I've taken the view that people might be a bit annoyed with me. They might think I'm a little bit inclined to move too quickly. But you've got to take a balance. Do we want things to happen or not? Are we I think we're looking down the barrel of a gun, quite frankly, with health provision becoming more and more complex and more expensive. But I can easily sit here. I can have a very easy life and come in on a Friday, sign forms and go home again. Nothing will happen. I won't get any criticism. But I'm quite happy to take whatever criticism's coming my way in order to get things done, because I think that's what we need. And I don't really, there's a fine balance, and I don't want to revert to being hamstrung by process, so that all we're doing is delivering process and not delivering any real change. So I know people might be critical of that, but there we are. That's.
No, I've got a lot of sympathy for what you are saying, Minister, because one can get bogged down in process very, very easily. But at the same time, you have to take people with you.
Quite right.
And in order to take people with you, people have to understand what the proposal is. That's all I'm saying.
No, you make a very good point, and I've sort of been drawn up a bit short this morning, and I need maybe to go and think about maybe trying to get a little bit more information out there. And I'm very, very happy to take this to the public, but not so much on a consultation. I know there's been controversy about this, but I think if you open things up for 100,000 different opinions on things that really matters about which people won't have an intimate knowledge, there's a danger. I think once we've decided on something, very happy to go to the public and explain, and certainly to liaise with the public about increasing charges. That's a different thing. That's going to be them putting their hand in their pocket. So that's different. So what we're trying to do is make progress. But if the message coming from here is that we're not really putting sufficient information out there, we can, with the limited resources we've got, because you've got to bear in mind, I've got small teams of people that are under a huge amount of pressure from lots of different areas. So I've then got to be saying to them, "Well, slow down a bit, we've got to go and do this, and we've got to do some more engagement," which is fine, but there is a very, very fine balance. And what we're trying to do is to try and get that balance right. In the interest, everything comes back down to the patient. And like I say, I see far too many complaints about far too many things. And I think we can do better.
Sure. Okay, thank you. So we'll await further information from you on publishing something to put some more information
Summary
out there.
document, 4 pages.
And the measures that you're going to use to measure the effectiveness.
Yeah.
Thank you for that. We're going to move on to a different section now.
Well, linking to the information that is out there, on the 14th of January, the Health and Care Services Division Annual Plan for 2025 was published. Can you just give us a brief explanation about what that document is and where it's come from, how it's put together?
Well, so the teams put that together. It's basically just a broad summary of what our intentions are for the 12 months.
Is it in lieu of a business plan, or will business plans for the different departments with operational delivery
Well,
follow?
each department works to a process, but I mean that's something Andy can elaborate on.
So there are plans that sit underneath that. So, for example, in mental health services, there is an annual plan that sets out a whole series of different actions, which of course relate to the overarching plan, but they're not published business plans. They're the plans for the service. This is our overarching HCJ plan for the year.
Okay.
Is it the business plan?
So I think
The Chief Minister made clear at the time of the budget that there would be business plans published for every department. So far, only the Treasury Minister seems to have published one. This doesn't appear on the business plan list. Is it the business plan? And if it isn't, when is the business plan coming?
yes, I think it must be in the absence of another plan. It is the business plan. Yeah.
This is the business plan. Okay.
Okay.
Thank you.
So, go on to the...
Yeah. And then on to the home birth service and the internal review.
Okay. Should I swap places with Andy? Or?
Minister, if you could stay at the table, but one of your officers could...
Ruth, you're happy to. Thank you. I thought I was going to be off the hook for 10 minutes.
Bit too eager, Tom.
That didn't work.
Good try, Minister.
Yeah.
So my name's Andy Howell, I'm one of the Assistant Health Ministers, and I've been working with our Director of Nursing and Midwifery on this.
Sure.
And she felt, well, it was thought that the home birthing service, we couldn't offer a safe service, and so that was why it was withdrawn temporarily.
Is you say it was thought you can offer a safe service. On what basis was that decision made, and was there any particular incidents that
Was based on the professional opinion of our chief midwife.
Do you want me to go with it? So I think it was looking at all of our staffing, workforce fatigue, being able to offer a 24/7 service for the home birth service. It was looking at the childbirth emergencies in the community. It wasn't looking at a midwife being able to deliver a baby. It's about if you had an emergency in the community and actually dealing with that, because obviously it's only midwives that you have that go to an emergency and go to home birth. So it was just making sure that they have got that expertise and that training. And when I looked at that, there was very few people who had that training. So therefore, to be able to offer it safely and efficiently, I had to make sure that I reviewed all of the training that was undertaken by each of the midwives. And that's why I said that if we temporarily suspend it, it means that we can review our policies, our procedures, and making sure that all of our midwives, because we have got a junior workforce now, we've got a workforce that might be in the first year or 2 years of qualifying, and I need to make sure that that training is for them so that they're able to provide the care within the hospital setting, but also at home. And it's not around just the delivery, it's actually around the emergencies that can develop that we are unaware of. So therefore that's why I've temporarily suspended it and then put on the training, which will be the childbirth emergency, so that all midwives then on the island will have that training. And it's not just the midwives who will have that training, it's also the paramedics. We've been working very closely with them as well to make sure that we've got a very cohesive training programme for all of our midwives and paramedics together.
Can I ask about the training, the new training that you're going to be provided? How is it different from the training that you had in place before?
So the training we had before was obviously was on island. It's very much, there's been lots of developments within the UK. We've had lots of different reports, etc. So the training it was undertaken was by individuals who, for different reasons may not have been in the service for various reasons, and therefore I wanted to make sure that it was very much the training that is highly recommended to anybody, and it's within the NHS that is something that they now are undertaking this training within all their organisations in relation to childbirth emergencies. So therefore I felt that Jersey, we needed to have the most up-to-date, reliable and safe training for it. That's undertaken by individuals who are highly commended within that process to be able to provide that training for them.
So is it a different training package?
It's a different training package in that it's up to date now. The training package that we were doing on Island before obviously was something that was done a few years ago, and now they have very much expanded that training, and that's through all the different reports that have come out in relation to various 3-year delivery plan for maternity across the UK.
And so that organisation is Baby Lifeline, who will be providing that, and we've got 40-ish midwives, I think is correct. Will all midwives be trained, and will it happen all on the same day?
So it can't always obviously happen on the same day, because we have got to cover a service 24/7 as well, and also we've got people who will be on annual leave, etc. But we have already got a second training date that will be going on later on in the year, and then our plan is then to actually work with them. We're going to do train the trainer. We're very much working with our practice development midwife and our clinical effectiveness paramedic, so that training will then be ongoing throughout the year, and we will have 3 courses every year going forward, and we'll be working with Baby Lifeline on that as well. And that's all in place.
How often do midwives have to repeat that, or should they repeat it?
So our plan is that we want to repeat it every year, and we always do medical emergency working together and training together is found that's gives us the safest care. So our plan is that it will become part of our training programme going forward for all of our midwives to do that, so that we're not missing out on anybody. So it will be absolutely every midwife in every year, but it will be 3 episodes throughout the year that we'll be doing.
Good. Can you state when you think the home birth service will start, if that programme is starting on the 3rd of July?
So I can do that training programme, but obviously then I've then got to present to our chief officer with all of the reviews that I've done, and actually with all the training, it's actually for him then to decide whether that will not be my decision, that will be our chief officer decision when that will be reinstated.
How long does that process take? So you finish your first cohort of training, you then decide what you want to do and present it. What sort of timescale are we talking
so
for
it's
that
always,
process?
obviously at the moment we're already doing that process. We're looking at all of the different policies, procedures, etc. So that will be once the training's completed, I will then be going to him with a paper to tell him about what we've done and whether I feel it is appropriate then for us to reinstate the service, and then I've got to assure him of everything within that paper to make sure that he's happy to give the go-ahead for us to go ahead with it.
You're not giving a timeline then?
That's not a timeline I think I can give, because I think that's up to our chief officer to make that decision.
Okay, and if there isn't the kind of go-ahead at that stage in time, will all necessary resources or whatever needs to be done to make the service available, will that happen?
I think we've got to be completely honest here and say that there's no absolute guarantee that the service will be reinstated. I mean, it was, if I understand it correctly, it was only ever a service that was available as and when it was deemed appropriate and the right people were there to do it. And I stand to be correct, but I think that's right, is it not, Ros?
It was.
It wasn't a full guaranteed 24/7, 365 service, and it may well be the case that we're not able to offer something we've not offered in the past, and we just have to be completely honest about it.
And I think from that point of view, it's that I've got to look at exactly every woman who's in labour at any one given time. We would absolutely want to be able to give it, but I've got to think about the ambulance service. I've got to think about every woman who's in labour, and if it is that we were very busy within our labour ward, it might be that I'm too stretched to be able to actually provide a service, because obviously we've got to send 2 midwives out. But we've been very honest with our women, and they already know that if the service was able to be provided, then we would, prior to the suspension, then we would be able to offer it. But they were aware that if it was that we were unable to, because our labour ward was busy with labourers at the time, we have to make sure that we're providing one-to-one care for all of our ladies, not just those who are in the community setting.
So when you say there's no guarantee that the service will be reintroduced, do you mean no guarantee it'll be reintroduced at all, or on a 24/7 basis? The
result of that will come when the work is finished, when the review is absolutely completed, and it'll be done on safety grounds fundamentally, and part of that decision making will once again have to be money and how much it's going to cost like I say, I think what we do have to do in the first instance is make sure that there's a first-class service for maternity service. And that's really, that's the core thing that we have to deliver in the first instance, and that will be done.
In which case, and I don't want to suggest that we delay it any further, but why are we paying for training before we've made a decision about whether we can have the service at all?
Ross can answer, but I think we need properly trained people. But Ross, I'm sure you're in a better
I
position to
think
answer
what
that
we've
than I.
always got to remember is that even if we haven't got home birth service, we could always have the possibility of a woman not realising she's in labour and then delivering very quickly, and actually we need to then provide emergency care for her with the ambulance service together. So even if we didn't have a home birth service up and running, we still should be able to provide that emergency care out with our hospital setting.
The
So
core
it will not ever
service,
be wasted.
the core service has to be as near perfect as it can be.
And in those scenarios, does a midwife go with a paramedic? Great. Okay.
Yes, absolutely, and that's why so our paramedics are attending this training with us as well.
Yeah.
So they're very much with us to do that training.
Can I just clarify this point, Minister, because are you saying that there is a significant possibility that there will be no home birth service reinstituted as a result of the review that takes place? None at all, other than the emergency situation?
I don't know that I'd go as far as to use the word significant possibility, but there is a possibility. What would be wrong here is to sit here and offer a cast iron guarantee that there's going to be a 24/7,
Not that,
365 guarantee, a service. Let's look at the review when the time comes. What's important is that all the nurses are properly trained and we've got a first-class delivery service. That's the main thing. The core service has to be as near perfect as we can.
And we really just want to make sure our women are safe and that we look after our staff.
Yeah, so in
And we
terms of...
we listen to what our head of midwifery is.
Yeah, I hear that. And in terms of safety, Jersey has a very high level of interventions and caesarean sections. Do you agree, Assistant Minister, that it is critical that we have these offerings such as the home birth service so that we can work towards reducing those rates of interventions?
Well, I think the intervention is only done for the safety of the mother and the safety of the baby. And I think sometimes we have to do those interventions. My daughter would be dead if she'd not had an intervention.
So
And
you
her
are
baby would be dead.
Yeah, sure. Are you aware that the rates in Jersey are much higher than in other jurisdictions?
Yes, I am. But I think that's because generally our mums are much more elderly and they have significant risks. Perhaps some of them are diabetic, they have high blood pressure. We do not do interventions unless they are necessary.
Sure. Can I ask Ross about that? So is it the age of mothers in Jersey that's the
I
issue?
don't necessarily think it's age, I think it's choice. And I think a lot of our women, that is through their choice. We very much look at any interventions, and I look at them every month. And the biggest part of it we look at is in relation to caesarean sections, the Robson criteria. And a lot of that is through choice, is that women might make that decision to do it. But we are doing an awful lot of work in relation to that choice and making sure that they're aware about our midwife-led unit. We offer tours now. We've done a new virtual tour, and we're working with our professional midwifery advocates to make sure that actually women know of all the choices that we've got within our maternity unit.
But the emergency C-section rate is also very high, which obviously isn't by choice. What's the reasons for that?
So that is always a clinical picture, and I think if the clinical picture is that they recommend, and obviously we do different categories of emergency sections, we look at them as well. We very much do, huddles around them to make sure that they are appropriate and they are done for absolute priority, and we make sure that we review them. So I think that again, that is, I wouldn't say we're no different. I would say there are a lot of trusts that within the NHS about what they're seeing about their emergency picture, but we have got to think about what is the safety of the mum and the baby at that time.
And in terms of your policy intentions, is it your policy intention to aim towards delivering a home birth service, if at all possible?
Yes.
Obviously a safe one.
Yes, of course it is.
Okay.
I think we've got to be clear, it comes into the category of desirable. There's vital, which is make sure we've got an absolutely first-class service, and the home birth comes into the category of desirable. And as we're going to see with virtually all other area of health, in terms of the difference between delivering a core service and what we would actually like to have.
I would just ask the Assistant Minister if you're aware of the public opinion on
Yes,
this
I
that differs
do-
from
I
that.
do
Sorry, I'll just
understand.
finish my question. That the home birth service is seen as essential to many women.
I think the essential services that we provide a safe service for everyone. That's what.
Yeah, safe
I mean,
home
a
birth service is seen as essential.
I don't know that it can ever be 100%. I mean, I don't think childbirth is ever 100% safe.
But are you aware of the views of the community that this is essential?
I am very much aware of it.
Just before we move on, I wonder if I could just ask, in the review to date, the course of the review to date, have any other operational issues come up that require investigation, or the scope of the review to be widened at all?
No, so I think I've fully done the review, and I've written the report, and that will go through our governance processes next week. It will be presented, and I think then the review report should be ready for everybody, but there's nothing. What we outlined was in relation to our staffing and our training and making sure our equipment was all absolutely up to date is what we found, and now it's just actioning and then.
Thank you.
Very quick follow-up, just picking up on something you just said, Minister. You said that the core service was the safe service and it would be desirable to have a home birth service. Is that something, therefore, that you might consider charging for?
That's what I don't think anything's out of scope in terms of what we have to look for, and that could be the thing that makes the difference. I was actually funny you should raise that as a question, but I was going to offer that up as a comment. So that could be something that we look at.
Okay. Thank you.
Say, and I know you're very passionate, particularly you two ladies, very passionate about this, and I get it. Okay, I might not be a woman, but I do get the desirability of that. And if money wasn't an object, you can rest assured we'll be looking to put that in place. But unfortunately, I didn't quite realise how controversial this job is and is going to be going forward. There's some very, very tough decisions to be taken and some very hard conversations to be had. Yeah, and it's not an enviable position, I have to say.
Understood. And just to note that we do, of course, have our own views on the panel, but
I don't want you to think
we're
because
here, of course, to represent.
male.
Sorry, I'll just finish. We're here to represent the views of the public, so we're reflecting the conversations that members of the public have brought to us, not just our own views.
And I get it, and that's what I want to say. I don't want you to think that I don't understand the desirability of this.
And I want to say that I have had, friends who've had a very wonderful home births, and I really, for them, it's been a great experience.
Yeah, that's the ideal, isn't it? Yeah. Great, thank you very much. So I have a very brief question on women's health. We haven't gone into much detail on this issue at this hearing because we're planning a specific hearing on this, which Minister, I've made you aware of, and we're looking forward to that. The Women's Health and Wellbeing Joint Strategic Needs Assessment Report, that was published recently. Can you just outline maybe some of the top things that you're planning to address from that report?
So there were 6 main things that came out of that.
As briefly as you can, I'm just noting the time.
So
thank you.
The most important thing that we want women on this island to thrive, and there are 6 main areas that we're looking into. So we want to have healthy behaviours from childhood, prioritising gynecological and reproductive health improvement, recognising wider determinants of health on women and girls, reducing barriers to accessing care and support, and addressing the impact of the ageing population and declining birth rate.
Okay.
So the Women's Health Group are going to be looking at those areas and then deciding what we should prioritise.
Okay, thank you. Minister, you've spoken about funding. Is there sufficient funding to address the issues raised within this report?
Well, I'm sure there will never be enough funding for everything on this island. We've got the drains, we've got the
for this
climate.
issue, is there sufficient
we
funding?
have to.
I think this is simply a case of doing as much as we can in each of those categories with the money that's available. Yeah.
And will you be seeking any growth funds in the budget this year?
Well, I think the women's, I'm sure we probably will have to do that. I think we'll have to.
I don't want to throw a curveball in here. It was only a matter of time before this happened, but I've been approached by a number of people recently who actually want me to set up a special issue for men's health. And yes. I think you might have seen somebody being interviewed on the television, a reasonably high-profile person about this. So we have that to contend with as well. And I think that probably is high time that we looked at some of the specifics about men's health. And I know the same question is going to be asked: will there be extra budgets for men's issues? And we come back round in this great circle of money.
Yeah, but we want everyone on this island to thrive and to have as good a health system as we can, and to live well, to stay well, quick access to diagnosis and treatment if you're not well, and then to be supportive of the long-term condition, and then to die well. So that sort of sums it up, really.
Okay, and to address the women's health needs, you may seek some additional funding in the budget. Is that?
Andy will be joining the queue,
I'll
a
be-
very long queue.
Yes.
Was that
Oh,
a yes?
well, yeah, yes.
Okay, thank you. Do you want to add anything, Lisa? No. In order? No. Okay, we're going to move on to the next section, which Deputy Brown.
I'd like to ask a few questions around departmental culture, Minister, because poor culture and low morale and difficulties of staff retention have been cited in a number of reports recently in relation to some departments in the hospital anyway. And it would be good to understand what is being done to address those issues. Your annual plan said that there was going to be created an organisational development strategy, secondly a people and culture plan, thirdly a culture dashboard, and fourthly a workforce strategy and plan. And I wondered if you might tell us how those things are progressing.
Right. Well, as you see, that's a plan for this year, and we're only beginning of March. So things are very, very, very much in their infancy. I think it's well recognised that there are cultural problems, and there's every effort being made from the executive leadership team down to recognise those issues. We've started a dialogue internally in terms of talking to people about what the problems are and trying to just collate all of that. In terms of the formal processes, Ian will probably be in a better position to update you on the points of detail. But it is a significant problem and something that we're all actually collaborating to try and resolve.
Can you give us some indication of what is happening now in order to address these problems?
Well, I'm in discussion. We've had a change of CEO. I'm in discussion with the current CEO. Unfortunately, he's away for 2 weeks, having an operation, about setting up not a board, not a formal body, but a collection of individuals to start trying to filter these problems through. I mean, we've got Speak Up Guardians, a situation which is working well. A lot of people now feel a lot more relaxed in passing information back up through the system itself, through the management system, and a good number of things are coming through to me directly. So it's a case of opening up, finding out what the problems are, and trying to piece together a method of dealing with it. And I have to say, there isn't any absolutely clear view. It's something that we're working on and trying to address as we go. But there are some formal points that we'll come to under the intersection.
I mean, if a member, for example, has evidence of abuse of the disciplinary system, where should he or she go?
In the first instance, to Ian, or to otherwise possibly to the head of the service, Leslie Darwin, and people are very, very free to come through to me, and they're now doing that quite readily. We have had meetings with the head of HR over the course of the last couple of months about sort of making sure that people are very clear about the rule book, what the rule book says, and the fact that the set of rules that we've got, employment rules, will actually be used more readily. I think things haven't. It's difficult to be critical of the past, but things haven't been as clear and as disciplined as they might have been, and I think there's a full recognition of that from Leslie downwards, right through the system, that we need to be very much clearer about what the expectations are, and if those expectations aren't met, that there will be consequences. So that's part of the cultural development process.
And I think we have recognised that members of staff have come to talk to many of us, that perhaps the processes have not in the past been followed correctly, and people may not have been treated as they should have been. So we're hoping that now the culture is starting to change.
So a full recognition, but I think it's probably useful if we, and Ian's sitting there anxiously waiting to speak, so I think he might be able to colour in the bits.
Recognising that we do have some hotspots where we have cultural problems, and I'll talk a little bit in a moment about how we're dealing with those. But I think we also need to be careful that we don't talk down the whole organisation, because actually when we take a look at our staff survey results, what they show us year on year is an improvement in morale and culture. So we need to be really careful that when we're thinking about those hotspots, which are definite problems we need to address, we're not painting the whole organisation the same colour. So I think that's really important. And our most recent survey, even though our participation rates are lower than we would like, showed increase across all of the dimensions of the staff survey apart from one, and particular increase around people's engagement with leadership.
And what do you put that improvement down to?
It's just been managers and leaders working hard at doing things correctly and learning the mistakes of the past, listening to all of the reports that we've had that have been critical of the service and not repeating those. And I think coming to much more of a honest, clear, well-structured process in the way we manage our people. I think some of the things which I'd like to claim, things like putting in a just and restorative type of approach into our policy framework, shows staff that things are done, they see that actions are taken. I think we still need to do more on feedback loops so that people understand that when they do speak up, what happens, and that they feel some closure on that. But I think our freedom to speak up work, which obviously centres around our freedom to speak up guardian, but not only, because we also have a range of freedom to speak up champions, and we also have all the line managers being trained on listening up and listening to people speaking up and encouraging people to speak up. Just that shift in culture of we would like to hear rather than we don't wish to hear has changed, and the numbers of people that keep speaking up have been really positive. I think other things that we've done in terms of being more human as a...
Can I just stop you there?
Sure.
Speaking up is all very well and good, but people who speak up need to feel that they've been listened to.
That's right, and that's closing that loop, as I said. Absolutely, and I think we need to do more and better that. We're not there yet. There's work to do there. I think, for example, the way we've been reaching out into the organisation recently, so just as a quick example for you, we had some anonymous reports of somebody reporting in social media that they felt bullied within the organisation. It was interesting to see the debate that was on social media. A lot of our staff saying, well, why don't you do this? Do this. They all seem to know the process. But I actually put a communication out to staff and said, just remember these things. And actually a couple of people have come to me. One wants to remain anonymous, another one is willing to, and said, I think I'm being bullied, can you help me? And absolutely, opening those doors to a culture where it's okay to speak up. I think we are shifting the dial on that. So I think we need to be careful not to overemphasise where we are. We are improving in terms of the culture. Our retention rates remain low. So remain stable and at a low level. So actually people are not leaving us. So there's this sort of myth that people are leaving. 5% of people leave us a year. A healthy organisation, you'd probably say you'd like 10% of people to leave you in a year. Our retention rates are actually very good. So we need to be careful because this becomes this rhetoric which can be very negative. The other things we've done, talking about some of the areas where we know we've got problems. So we've got focused interventions going in there with our OD team. So we've got training, we've got listening events, we've got appreciative inquiry sessions, we're delivering psychological safety sessions. So we've got, and also often it does require us to look at, is the leadership in this area right? Are they being properly supported? Do they have the skills and capability to lead these areas? And I think one of the things I would say is on the areas that we're moving to, and as you talked about us developing a people plan this year, one of the big areas of that people plan is to develop the capability and capacity of our managers to manage. Because actually, this is not about the top team. This is all of the levels of management in organisation. And if a manager is not managing well and is not capable or competent to do that, we need to support and train them better to do that.
What does that look like?
So I think, with Leslie, as the Chief People Officer, we've agreed we're going to look at leadership and development approaches across the whole of government, but particularly how well they fit for health. Because sometimes the broad brush of leadership and development training for government, it doesn't always translate into a care environment. So I think we need to look at that and about the specific leadership things that we need to do. So, for example, we're just closing off on the Cohen-Brown programme you'll be aware of for executive leadership. There's an opportunity now to look at where we go next in executive leadership, where we go with the world-class leader stuff that goes below that, and the espresso training that goes below that. So we're looking at all of those, but I want to look at it through a health lens, because I think thinking about collective and compassionate leadership is more important than the perhaps service performance leadership that perhaps is more fitting for the rest of government as a service provider of tax, or, you know, there's a different vibe, and I think Leslie's hearing that, and we want to get into that.
Thank you.
Can I just say that we want to just say thank you to all the members of the staff throughout the organisation for everything they do, and that we want all of us to support them and to go forward positively, because I think it's really hard when they keep being slapped down. So I think we need to empower them, and I think we need to listen to them, and you know, I think we all want to do that.
Yeah, I'm sure that's echoed by everybody in the room.
I'm glad Ian's spoken. You can see why I was so keen to introduce him in the first place, because there's a lot of internal work that's happening.
Yeah.
So
I think
just in terms of, just one, may I? Just in terms of symbols of this, so we have our STARS Awards every year. This last year in our awards, we received the highest level of nominations ever. So this is people being nominated to say, well done, thank you, you know, that sort of formal recognition, which is not the answer, but it's an interesting indication of where we are.
That's
So
great,
I think the point. Oh, sorry, no, go on. The point is well taken about the hard work and the need for appreciation. But one of the things we hear continually is that a lot of people on the front line do work incredibly hard, but they feel like they have concerns, and you would call them probably hotspots in particular areas, where there are problems with authority figures not responding to challenge, with people who have done things for the same way for a long time and aren't changing, problems with bullies, frankly. You know, isolated hotspots to be sure, but they are the thing that spike in the public consciousness. So could you address those specific kind of problems?
So those types of areas, I've said, where we've got the hotspots. So one of the things, obviously, that the Minister has, through his advisory board, we have a People and Culture subcommittee. That People and Culture subcommittee, meets every 2 months and scrutinises in detail what's going on in the organisation from a staffing and culture point of view. They will oversee the development of the workforce plan, development of the people plan, which is an organisational development plan this year. Also within that, we're developing, and we've sort of got an outline, but we're developing what we're calling our culture hotspot sort of thermometer. So that board will actually spend time looking at the areas where we've got hotspots and understanding what we're doing about it. So I think, again, we need to be careful that we don't talk in big generalities about there's a huge problem in this organisation. We have problems and we need to deal with them. So we need to identify them, which we have done through the cultural dashboard, and then we need to put a range of interventions in. Now, these are people interventions, so they're not simplistic, and we don't go in and just start sacking people like you might do in a private sector organisation. It's about supporting, training, developing, reflecting, dealing with the issues, and that takes time. It's a slow shift to change culture. But all of those things, since I've been here since last June, I recognise all that activity going on.
Well, that's very helpful, Ian. Thank you very much indeed. And I'm sorry if I mentioned poor staff retention when there was no evidence of that. I don't know how
it's a very common myth.
Yes, well, I don't know how these things happen. Can I just ask you about whether there's any, or maybe the Minister, whether there's any information you can share with us about the review of neurology services by the Royal College?
Andy, I think that's something I'd have to explain to you.
So this was the invited review, wasn't it?
Yes.
Yeah. And we haven't had the final report, but we've had the briefing report. I was really, really impressed by the report. They were very, very complimentary of our services. They obviously they will have some areas for our improvement, which would be brilliant because we're always trying to improve. But actually, it was a very, very powerful, very strong report. Gave very, very strong feedback, complimentary feedback for the staff and leadership within that department. So I think we were really pleased with it and look forward to the formal report. And obviously we will, as we always do, develop then an action plan to address the areas of improvement.
Are there any other reviews this year?
I'm
Invited
not the best
reviews.
person to ask.
Minister?
It's a shame,
We can check.
Tom, mate, we can
we'll
rule
confirm
that out,
for you.
that's fine.
Yeah.
Yeah, it's a
So-
shame
so
Tom,
this-
if Tom was here,
Yeah, so this was the neurology review that you're speaking of, so that's already concluded. Okay, and were past and current patients able to contribute to the review in any way?
I'm not sure that that's the mechanism of the invited review. They have a methodology by which they do their Royal College review.
Okay, and what was the cost of the review?
Off the top of my head, I'm not sure.
Sorry,
We can
Julia.
let you
Sort
know.
of funny, I've got an idea of what it is, but I don't want to misquote, so, yeah.
Thank
And
you.
when can we expect the formal review and will it be public?
Yeah, we've made a commitment to publishing reviews, but then we go through a process. When the review's finalised, we review it to make sure that nobody's compromised. And I think we set out a timetable last year as to how long that would be. I mean, we give us a certain number of weeks as a maximum to make sure we've checked it through. And it's not with a view to for twisting it. It's to make sure that nobody's compromised as a result of it. Then it gets released.
Yeah.
So it will be in all reviews come out.
And it will definitely come
Yeah.
to the scrutiny panel.
Absolutely.
And so do we know when that timeline is, when we're expecting it to be published? Is it?
I'm sure we do, I don't.
Yeah.
So I'm sorry.
That's something that Tom would have if he wasn't.
Yeah.
if he
Can
wasn't
we add
in
that
this
to the
process.
list of things to come back?
Yes, could we have a buffer so that before it's released to the public that we could have a look at it?
Yeah, we'll try and make sure there's I think we've already, did we not issue a schedule where we said that we X amount of days that would go to CARMIT, would go to scrutiny, then go out to the public? And I think we've got a format that we work to, because there'd been some controversy about different dates and some stuff not being released. So we wanted to have total clarity that all stuff would be released and it would be released against a programme
Yeah,
on a timetable. So we
That's
can revise
great.
that, but we'll try and make sure that we stick to the
Thank
timetable
you.
that
We
we've
appreciate
put in
that.
place, because I think people have that as an
sure.
expectation. Yeah.
Thank you.
Now, I was just going to ask if there are any other reviews commissioned for this year.
I should know, but off the top of my head, no. But once again, we'll certainly come back to you on that when Tom's back in situ.
If you had to choose the next area for review, which area would it be?
Crumbs. I don't. It's not something that off the top of my head I could tell you. But as I say, Andy might have an idea as to what's more more pressing.
I don't know what the area is, but I think the way, just to give you some assurance in terms of how we would go about that. So in terms of our risk management processes, we would be looking at our risk registers, we'd be looking at our serious incident reports, we'd be looking at complaints and compliments. If there was a cluster of those, that would lead our attention to areas that we think we may need to do a deep dive on.
Yeah.
And obviously the Royal College review or whatever is a mechanism of deep diving.
Yeah.
We also need to be clear that external review isn't always driven by concern. It should be routine.
Yeah.
So the
We're
get
gonna
it
try
right
and get
first
to
time
just-
reviews, for example, is something we should just be doing.
Yeah.
Continuous quality improvement.
Yeah. But would you say, Minister, that it's important that members of the public do give feedback on services so that those clusters can be identified?
We've got to be a little bit careful, because as Ian was saying, that Royal Colleges, when they come over, they've got a set way of doing things, and I think that may be more appropriate in some areas than others. Specialist areas, not for me to really comment.
No, I
but
mean
think they have a
feeding back through the established kind of government mechanisms on the services. That you're nodding there. Do you want to comment on that?
I mean, no, I'm just saying, I would absolutely agree with you. Our mechanisms of listening to the public, the patient engagement panels, the patient engagement work that we do, as well as monitoring of complaints and compliments, etc.
Great.
This is all intelligence to help shift our focus, isn't it?
Sure.
I
Thank
think
you.
if the medical director was here, he'd be probably closer to the areas that would need addressing next.
Okay, Minister, there were some recent media reports relating to incidents of sexual assaults on staff within the department. I think there were 20 formally reported incidents in a span of 4 years. Can you confirm if those reports were alleged assaults by members of the public on staff, or was it staff, or both?
This is a matter that I have to hand straight to Ian.
Yeah, it was public on staff. They were, the majority of that, they were over a long time, and obviously what is classified as sexual assault, we all immediately think it is the most serious type of sexual assault. It may be inappropriate touching, it may, it's not necessarily, I think people's minds tend to jump to the most serious. A lot of those reports are within services where we have people that are perhaps not in their normal consciousness, so they're not acting as they want. So, but obviously it's very important that staff report those to us, because we need to look at our processes to make sure that we're supporting and looking after staff and protecting staff in those areas as much as we can when they're on the front line dealing with the issue in the moment. So if somebody having a psychotic episode, whatever their behaviour is, that's the situation you're trying to deal with. That's the nature of health and social care services, really.
Thank you. And have there been any recorded incidences of either staff on staff assaults or staff on public assaults in the last 5 years?
Not I'm aware of.
Can you confirm if Unite's suggestion of a full review of previous cases and an assessment of where learnings and improvements can then be made to reduce the incidence of these events, is that suggestion going to be taken forward?
To be honest with you, that's an area that I've not had a great deal of focus on, and I have wholly relied on you.
So I don't think a decision has been made on that yet. I think
Okay.
there's a group that's been established to think about this and to think about violence against staff as well. So the two are very clearly interconnected. And I don't think a decision has been made yet about what exactly should happen next, but it's certainly for consideration.
Thank you. And what's the timetable for making a decision on that?
So the group has met twice, I think, and I think is due to meet again in 2 or 3 weeks' time. So, and that's as much as I know. I need to.
And the decision will be made at that meeting?
So I don't know that because I don't sit in that meeting, but we can certainly find out whether that's something when they will decide. Yeah.
Yes. Could you establish the
That'll be on the
timeline
list
and
of
get back to
things
us?
to respond to.
Thank you. Okay. I think then next one's you.
Well, I hope this is not misinformation too, but the Bailiwick Express recently reported that Jersey's health department is seeing a high number of staff off sick with anxiety or stress, and I wondered how you were addressing that suggestion.
Thank you. Our sickness levels are higher than we would like them to be. They are in line with the jurisdictions. So if we look at our nearest neighbour in terms of the NHS, we're fairly on par with them, and we've seen the same rise in staff sickness levels that the NHS has seen. There's some sort of post-COVID thing. I think we're all looking at this and trying to work out exactly what is going on. And there is a general population increase in sickness post-COVID as well. So there's some things going on that we're not sure, and we're seeing those being replicated within HCJ. In terms of our level of sickness that is down to stress and anxiety, they're about 12% of our total sickness reports. You know, the highest ones as ever are cold, flu, COVID. Then we have gastrointestinal, and about 3 or 4 down the list is stress and anxiety. So they concern us, obviously, and we look very closely at those. The board, again, the Minister's Subcommittee on People and Culture, very interested in this. We're very concerned about what it's telling us about health and well-being of our sickness levels continuing to rise. What we've done in the first instance is to redouble our normal sickness and health and well-being actions. So we've gone through 2 reviews now of everyone that are on long-term sickness to make sure that we're supporting their health and well-being as much as we can be. So we're aware of everyone that's on long-term sickness, that's over 12 weeks, is being reviewed and has been reviewed by their line manager, supported by HR. We're now working with managers to look at shorter term sickness, so regular patterns of sickness, people that go above trigger levels of sickness, and actually making sure that health and well-being reviews are being undertaken properly. Occupational health services are being used, staff counselling services, employee assistance programmes are all being deployed appropriately. So all of those things that we're obviously monitoring very closely, and we've put in place all of those normal management actions that you would expect. We now, I think, need to let them run for a little bit to see whether we actually see any impact on those. But
Do you know whether the figures are higher in the health department than in other departments in the civil service? Education, for example?
I'm not sure. I haven't looked in detail at the comparator.
That would be significant, wouldn't it?
Not necessarily, because I think it's a very different business. I think the comparators we tend to look at the other island jurisdictions, the NHS, people that are involved in delivering health and social care services. It is different. When I was in the NHS, I would look at other NHS providers, not at civil service, because it's a different business.
Can you advise what those figures are and
We
where
are
you're comparing?
broadly in a similar, there's nothing that stands out for us either when we look at the determinants of sickness below the headline figure or the headline figure. We're not stepping out of where everyone's trending.
So when you say everyone, you mean UK, Isle of Man, Guernsey.
Exactly.
Are there any jurisdictions where perhaps the minister may be aware of some that he is aspiring towards that have exemplary healthcare systems that you could compare those levels to?
I'm not aware of anywhere that's doing anything remarkable. I'm less aware of, or I'm less using benchmarks for more international, because we get into real issues about how things are counted.
Okay.
And also we get into issues of, especially within, for example, private healthcare providing, such as in America, where staff are not paid for their sickness, so they get, you get skewing figures that means it becomes very difficult to compare your data. So I've tended to go with the jurisdictions that are more like us, but it is something that we're focused on. It's a worry, not just in terms of the availability of staff to deploy for patient care, but actually how well are we looking after the staff in terms of health and well-being.
Because we'd hope to be much better than, say, the NHS levels, wouldn't we, ideally?
Yeah. So we aspire to be better than the NHS.
Does the health department conduct Schwarz rounds? And
We do, yeah. We have they've been very successful actually, and we've had lots of positive feedback on them. So we're a licensed Schwarz round provider. So they run regularly. There's one coming up imminently. Is it today? Yeah. This afternoon one's running. So, and they are a great place for people to provide peer-to-peer professional support, explore through storytelling, and if you're aware of how Schwarz rounds work.
You say it's a great success, but we haven't seen any output change.
Well, we may be either holding back the curve, so rather than seeing a reversal, we may be seeing a slowing down. But actually, just in terms of success factors for me around Schwarz rounds are how staff feel about them, their feedback in terms of, did I feel supported, did I feel I had a place to take issues and problems. There's a multiple range of things that you need to do in order to support people's psychological health and well-being in the workplace. This is one of them.
Just make a point, I think the most important measure for us, we talk about comparing with other jurisdictions, but in the longer term, I think what's important is how we compare to our own figures going forward, and what that figure might look like 12
Do you mean
months
population level?
Yeah. What that figure might look like 12 months from now.
What is it, incidentally, the levels of anxiety and stress? You said it's 12%. Do you know how it compares?
12% of our sickness is not 12%.
Sure, yeah. What is that compared to population level percentage?
Where we would respond actually. We need the stats department here, don't we?
Yes, we could do with them around at every hearing, really.
In a health environment, you're going to get a little bit more stress than you would get in a
We
standard
could definitely look
environment.
at what the reported levels of psychological sickness
Yeah.
illness are.
Thank you. Anything? Do you want to move on to the
Move
next
on?
one? Yes, go ahead.
Preventative health measures. So the annual plan talked about preventative health measures, and you've spoken about the importance of that, and indeed in the UK there's a huge focus on preventative health. It's not specifically detailed in the service objectives for 2025, and I wonder what that reflects.
At the moment, like I say, once again, where we are at the moment, it's budgetary constraints that don't allow us to do anything a lot different year on year. What we have been doing, and you're going to elaborate on that a little bit more, is a lot of work about what changing from a reactive health service to a proactive health service would look like, and putting some numbers alongside that. And as I've said before, with both digital and preventative health measures is something that we'll be bringing to the Assembly, as you know, as part of a bigger package of requirements.
So you mentioned in your forward to the document, I think, things about health monitoring and initiatives for healthier living from a young age.
Yeah.
What's going on in that space?
Well, as I say, I'll hand over if you're happy to, and then we'll take some questions afterwards so that you get the full picture. Rather than have a half-baked picture from me, you get the full professional picture.
Yeah, and I'm just noting the time, so Francis could be
I'll rush-
succinct as
I'll
possible.
rush through.
Thank you.
There is some activity already in the prevention space. The DPH annual report really made that case for change to really show that actually a lot of the common disease is preventable just through healthier living, making sure you don't smoke, eating well, more exercise, all of those sorts of things. So we've been doing a mapping exercise to really kind of understand what we're doing already, where the gaps are in terms of best practice, and what the evidence is around prevention. And we know prevention is better than cure, and that's very much about starting, you know, as early as possible in childhood, really. So the JSNA work as well has showed that we've got significant numbers of our young people not doing enough physical activity. They've got poor mental health and well-being. So we're looking at opportunities for investing in whole system approaches where we really make the activities available to children, young people and families. That also helps with things like childcare potentially. So we're looking at implementing a range of positive activities. We're looking at increasing access for families on income support to be able to access more positive activities. We're also looking at things like dental care and the dental service, where we know that 98% of dental disease is preventable, and we have 25% of our under fives with some level of dental decay. So we're looking at moving that those services out into the community and making them much more consistent. We're also in the adult space making sure that there's targeted pathways and interventions. So, for example, we have almost 4,000 people on the pre-diabetic register with their GP. And they get an annual review, but there aren't any services that are put in place to turn that curve and stop them going on to develop diabetes. We know that 40% of diabetic cases are preventable. So we're looking at the life course really, and what services and systems we need to put in place around improving access to physical activity and lifestyle, around improved screening, around vaccination uptake to keep people safe. Around community services such as GP and dental care and pharmacy, and then moving into more of that kind of earlier diagnostic support.
Yeah, and can I focus in on the diabetes, for example? And you said you need to put things in place. What kind of services would that look? What would that look like to a member of the public? What would they receive?
So we're working actively on the diabetes prevention service at the moment. We have a kind of oversight group with a range of people to help us design that.
Yeah.
So the way we're looking at designing that at the moment for ease, really, to get a sort of local pilot to see how it would work locally, is to take some of the evidence-based practice for pre-diabetes reversal, diabetes reversal programs, which focuses on living well, on physical activity, on weight management, all of those types of things. We've been working closely with the GPs to look at the targeted register that's available through JQuIF.
I just wanted to, so for example, physical activity and weight management, what would that actually look like? Would it involve free use of the gym facilities? Would it involve subsidising healthy food? What would that look like?
There's a targeted UK pre-diabetes evidence-based programme, so we're adapting that for Jersey. So that would look like a lifestyle, lifestyle interventions ranging over a year. Support and group work. It could involve referral to Move More through Jersey Sport and other physical activity programmes as part of an integrated package of care. They sort of take a year, the programmes, because to have that behavioural change takes a while.
Minister, the implicit, or actually quite explicit, I think, implication of this is that resources have to shift from treatment to prevention and into this public health. So we have a heavily constrained, in fact, increasing demand for treatment budgets. Yeah. How do you get from that increasing demand for treatment budgets to providing more resources into prevention?
You use the word shift, and I have to say that's a word that we can't use because we cannot shift a single penny from where we are.
Even though you plan to save money through these.
Unfortunately, you don't get the improvement till you've invested over a year time.
So we're probably going to need some more money to carry on doing what we're doing, because as I say, science and technology delivers more and more treatments, more and more drugs at more and more expense. That's on the one hand. And if you want to try and just shift that model to make the savings, you certainly can't utilise that same money because you haven't got enough of that to keep doing what you're doing. What this requires is new money, and it needs upfront money. That's going to be quite a long-term investment, but it also, if you look at what's required to set this up and get it all underway, if you're vaccinating, so on, get everything up to date, you need sort of a bulge of money over a 3-year period. So you need that initial input of money to set everything up and to bring everything up to date. Then you've got to carry on with a certain amount of money in addition to your money for those savings start to come through. If you never address that, you're on the back foot for good and all, and that's really difficult. I mean, I use the instance of stroke, and I think the figures were, I stand to be corrected, showing the medical directors not here. I think we had 9 strokes in the first 6 weeks of this year. And when you talk to the head of the heart department, an experienced guy tells me that with the right kit and the right system, up to 80% of those strokes could be avoided. But you need monitors on people's wrists so that when they get atrial fibrillation, you bring them in, you put a pacemaker in, they don't have a stroke. When you have a stroke, strokes and heart attacks, I forget which way around, one costs $250,000, the other costs half. So I'm not sure which way around those two go. But these are colossal sums of money and involve a huge amount of misery for the people involved. And if we can shift from that model, and I think every health service everywhere is trying to do it, I think we've got to make a decision here as to whether we want to stay on the back foot doing reactive health and accepting all of that's going to mean, or whether we want to make this fundamental change to try and tackle the problem to get the preventative work underway. It's a big one, and that's going to be tricky. But that's where we are. We're doing the preparatory work, and we're going to come up with a number and a programme.
This year?
Yep. Yeah, we've got to get this done ahead of the cycle. At the end of the island might decide, and the Assembly might decide that it's not a route we want to go down. That's fine, but then they have to face the fact that their health costs are going to escalate and continue to escalate, and we won't be tackling issues.
And so you will be proposing something, presumably in the budget or government plan, that will address this.
Correct.
And it will be a funding. It will involve more money from somewhere.
And be warned, it'll be a fairly sizable sum of money because you don't do this on threepence, do you? It's not
tens of millions.
Tens of millions, yeah, it is. Yeah. But it's a debate that we have to have. We can't keep backing away from these things. They're realities. Every health service on the planet is looking down the same lens and saying, how do we go about this?
Thank you. And can I just ask, how important is it from a preventative point of view that we do achieve this, that the Assembly approves these? Like, how important is it for the health of the island?
I think it's a crisis. I think, and the Health Minister's spoken to this before, I think need is increasing. We've got an ageing population in Jersey which is bulging and coming up, which is about to hit us quite fast. So I think we have to do something. It's difficult to take direct costs out of the system by doing that, as we've alluded to, because you've got your health spend going up, but it stops going up so fast. I mean, that's what we're trying to achieve. And also it's not just about preventing people getting poor health, but it's also those that are already in poor health, it's managing their conditions better, because the cost of not managing, uncontrolled diabetes, for example, costs, a fortune in terms of people going blind, losing legs, losing limbs. These programmes that you put in are not just about sort of keeping the island as healthy and well as possible. It's also about stopping that progression, which we know is happening.
And if this investment does go in, so to maintain the service as it is, plus this additional investment that you're talking about for the preventative measures, how certain are you that it will start to bring down the costs overall, that these measures are like, how certain are you that there are effective measures that we can do to improve health?
So we've seen it from pilots operating in other places. In spite of getting the funding, we're going to move ahead with the diabetes prevention service. So we're estimating that we can operate that service for less than £500 a person as a one-off. But you're looking at sort of over £5,000 of spend a year on a current type 2 diabetic patient. So, and that's for the rest of their lives.
And certainly if you stop people smoking, for example, then you stop them getting heart disease, lung cancer,
Is there anywhere in the world that's getting this right, the prevention side of things?
So there's lots of talk about it. There's no one's really sort of bit the bullet with it, really, is fair to say. But I think one of the other challenges we've got is the inequality piece, because actually if we look at those unhealthy behaviours, they tend to be more prevalent in some of our lower income groups. So for example, smoking is over 30% in manual labourers and workers compared to 7% in senior management. So it's not only getting the funding and the investment and the programme right, but it's also being able to target that and making sure that we target that our most vulnerable groups to really turn that curve.
Make a point, you talk about evidence, and I don't think anybody's tackled this head on and done the whole thing, but there are a lot of places that have tackled individual things where they've done pilot schemes or they've done a limited amount of stuff. And I think, talking to Peter Bradley, he said there's an awful lot of evidence. If you collate all of that evidence, then it shows you very, very clearly that it does work.
Yeah.
But it works over a period of time, and you've got to be prepared to go through the pain that's required. And it's gonna be a complete lifestyle changes. I mean, when I was a kid, you died at 70, 71, and that was an end to it. We're now living till 82, 80, 85, and I think the idea of retiring at 60 and having a 20-year retirement, I think we're gonna have to be encouraging people to work for a considerable amount of time longer. So I think there's an awful lot of changes that have to come into this to make to reality checks from people, because I think, in fairness, we've all become sort of quite entitled and quite used to extraordinarily sort of high standard of living and a low tax, and just think that there's some big implications here.
Thank you.
Where does responsibility for that piece of work sit? Is it being led by public health? Is it you as the minister?
Well, it's being effectively driven by me as a sort of a requirement, if you like. The public health are doing all the background work, but they're liaising with all the different departments. So there's a lot of integrated work happening. It's not just happening with public health in isolation. They're talking to everybody to try and make sure that it's a robust piece of work.
And you're the lead minister on it.
Yeah.
Okay, thank you.
Okay. Do you have any further questions on any of the sections? No. Okay, Minister, that's all of our questions for today. Do you have anything?
Not quite. We've got lots more.
Well,
but
yes,
we're
we
gonna
will
have to
have some that we'll have to
Fine.
forward
We'll
on to you.
put them in
I hope you found it fairly
writing.
helpful.
Sorry.
I've gone on to all your questions, but I think you can see the team are doing a lot of work, and I thank them all, because I think I hope you agree, there's some really good progress being made. And as I say, this isn't something that's going to be solved overnight. The plan is to get a first-class health service by the time we move into the new hospital. It's a 4.5 year plan, and I think I don't want to speak too soon, but I think things are going well, and there's a real desire amongst the team to get things right. And thank you for your questions. It does keep us on our toes, and I'm very much looking forward to digital when the time comes, because that's going to be a vital part of what we're doing. So hopefully you'll put that at the top of your agenda next time.
Good. Well, thank you so much for your time today, and thank you for all the work that you've been doing across the departments. And I'll close the hearing. Thank you.
Thank you.
Is it still online? Okay, we're still streaming, just so everybody's aware.
No bad language then. No jokes. We do those outside.